that, let me shut this down. Our findings are that about 20% of people with a continental ileostomy during their life will need either a minor or a major revision. A minor revision is where perhaps the stoma gets too tight. And sometimes people form too much scar tissue, even though they're putting in a catheter several times a day, which keeps it open, you can't keep pinching down. And so then you have to do a revision. Sometimes we have to make a new stoma, but preserve the existing pouch. For people who have a slip valve or a fistula, their reoperation will be more major because we have to go back in through the main incision and back into the, internally into the abdominal cavity in order to work on the pouch, to restabilize the valve, or sometimes we make a new valve. We keep the existing pouch, there's no need to remove it if it's healthy, and we take a short segment of intestine, attach it to the side of the pouch, fashion the valve and stoma from that. Now you have a new valve and stoma, same pouch, and no intestine was removed. And remember, the intestine of the pouch is functioning intestine, so it keeps digesting. It's a nutritional benefit. So that's the formal presentation. I know that's a lot of information, and we still have time. I'm happy to answer any questions or get any input. How many people have a continent diversion? Okay, so how many people empty their pouch once a day? Twice a day? Okay, 3, 4, 5? I think that's everybody. 5. All right, so small sample, but you see the range. And same thing with J pouches. There will be a range. Some people will actually evacuate 3 or 4 times a day, and that's it. And some people, it'll be 6, 7, 8 times, but without that tremendous urgency of colitis and without the illness of colitis. So life is full of trade-offs. And you know, we think that the normal Western world, with the diet we eat, that there should be 1 bowel movement per person per day. And point of fact is, many people are not in that range. Some have fewer, some have more per day in the absence of any bowel disease. Once we have to remove the colon, we're never going to get to that point of 1 evacuation per day, except for a patient who only empties their pouch once a day. And that's certainly compatible with a long and happy life. It's not the most common. With the J pouch, most people are in the bathroom 4 to 5 times a day, but all of us are in the bathroom 4 to 5 times a day and empty our bladder. I mean, that's part of the human condition. So remember I said the 90% rule. And it's interesting how it came out that way. But 90% of people with each option, standard ileostomy or continent diversion, J pouch continent ileostomy, end up very satisfied and with an excellent quality of life. Yes, ma'am.
What kind of screening do you do to see if somebody's a candidate? Can you do your own procedures, or you look at doctor's reports, the surgeon's reports?
Okay, well, for someone who's already had surgery,
yeah.
I like to look at the operative report of the prior surgery and the pathology report. Obviously, you take complete medical history, and height and weight is helpful in terms of nutritional balance, but most people who've had their colon removed already and have a conventional ileostomy are going to be in good health. And in fact, many people, once their colitis is in the pathologist's office, they don't need a doctor anymore. And so many patients I see, you know, they had their ileostomy, whether it was a year ago or 10 years ago or 20 years ago. They're now in their 30s or whatever, and they're healthy, they don't see a doctor. So if I'm concerned about, and I always have a personal conversation with a prospective patient before we decide, okay, let's schedule surgery, like any other patient in their operation. But if I'm concerned, I would say, well, let's have you see a local doctor, get some blood tests, see what your protein level is, your albumin, your blood count, that you're not anemic. But most people with a conventional ileostomy, where there haven't been complications, are going to be fine.
So, but do you check the colon to make sure it's viable, that it's not inflamed, or that it's going to be healthy enough to use?
Well, in this case, you're talking really about the small intestine being healthy enough. And that's a matter of what's going on in that patient's life. Looking at the pathology report, confirms that the patient didn't have Crohn's disease, because that brings other considerations into play, and it's more of a decision-making process. So if we know that the colon was removed for ulcerative colitis or polyposis, and you have a conventional ileostomy and you're in good health, you're going to be a candidate for the operation. And it then becomes a question of, should you have the operation? Is it appropriate for you to have it? The risks and benefits of it. Yes.
Do you ever take people from colostomies? Because you're always thinking of ileostomies. Do you take them from colostomies to continence?
Okay, I'm glad you asked that question. It depends on where the colostomy is. For many people, for example, who have had cancer of the rectum, and their rectum has been completely removed, rectum and anus, and they have what we call an end-sigmoid colostomy. That means 90% of their colon is intact, it's normal, it's healthy, and they have a colostomy at the end of that. Those patients are usually better off staying the way they are, because if you can irrigate your colostomy once a day, with an ET nurse kind of showing you how to do that, you'll spend the rest of the day continent. Most people with an end-sigmoid colostomy, who don't have irritable bowel syndrome or anything else, don't wear an appliance. They flush out they enemize their colon. That means all this waste and gas is evacuated. And now most people eating normally during the whole day, nothing will come out, because you've cleansed it completely. And it has enough capacity, you have still 90% of your colon. Now, if you had more colon removed and you have a colostomy that's closer to the right side where the small intestine joins, that can be very difficult to manage. And there's a lot more watery output, it has more odor, you can't irrigate it thoroughly and expect it to be continent. So then we're saying, well, you have 50% of your colon left with a colostomy, but that's not an ideal situation, and you may have much better quality of life having that remaining colon removed than have a continent ileostomy. So then becomes a discussion between you and the surgeon you're consulting with.
So, how much ileum do you need? Do you have to have, because I've had small bowel resections.
Okay. Well, as I mentioned, most of us are born with 20 to 30 feet of small intestine. And many people have had operations between colitis surgery and whatever else went on, where segments of small intestine are removed. So I mean, it ends up being a matter of how much. So if you had an operation where 6 inches of small bowel was resected, that would be meaningless, 20, 30 feet. But if you had, 3 feet of bowel resected, that may be more of an issue. So to help determine whether you would be a candidate for a continent diversion, what I would recommend first is that you have a GI series. You swallow old-fashioned barium, they watch it go all the way through to your stoma or your colon. If you had bowel resection, your colon's still there. And we get a pretty good estimate of how much small bowel there is. If there's very little, then we're not going to find more at surgery. But usually we get a picture that between operative reports and the GI series, we get a very good appreciation of how much small intestine is in that person, and therefore whether they're going to be a candidate or not.
Do you always make a pouch out of the ileum, or can it be made out of like ascending?
Well, the pouch is made out of the small intestine because people who have pouches are going to be losing their whole colon. There's not going to be any part of the colon left. Because to cure colitis or polyposis, we have to do a total colectomy. So then we're just talking about the small bowel is all that's left.
Dr. Schiller, how much of the small intestine do you use for a first surgery to make a pouch?
To make the pouch uses up about 1.5 foot to 2 feet of intestine.
Mm-hmm.
And we did, for a period of time when we were dealing with Crohn's disease patients, where they had Crohn's limited to the colon, we would make the pouch out of the jejunum, the upper part of the small intestine, because Crohn's typically attacks the ileum, the lower part, first. So we make it out of jejunum, then we kind of transpose it to the very end, and then reconnect the intestine. But that didn't really make a difference. And some people will get Crohn's who never had it in their small intestine, only in the colon, will develop it in their pouch, whether the pouch was made out of the ileum or the jejunum. And so usually it's made out of the ileum. It was similar to the J pouch.
Is it possible to make it out of large colon if there's no colitis or no Crohn's?
Well, if the large intestine is normal, then there wouldn't be a reason to do a continent ileostomy. You would use your large intestine. even if it meant having a Boston.
I think what she's asking is, can